I'd like to thank Mike and Ben as well for allowing me to speak today. These are my disclosures. Recurrent posterior instability is relatively uncommon. The signs and symptoms can be subtle. It's often a misdiagnosis. Laxity and instability are not the same. Laxity varies widely, and there's overlap between normal and unstable shoulders. These are the normal posterior translations by several authors. The anatomy has static factors as well as dynamic factors that can maintain posterior stability of the shoulder. That includes the position of the scapula on the thorax, which acts as a shelf, the acromion, the scapular spine, and the rotator cuff, both as a static and dynamic. Posterior stabilizing forces in general are the posterior inferior glenohumeral ligament. The superior and middle glenohumeral ligament act as secondary restraints, and this is part of the circle concept of instability as described by Warren and others. So here we see the here we see a pointer. Well, okay, so the classification can be acute. They're varying classification systems: acute, chronic, and recurrent. That can be the timing and frequency, degree, direction, etiology, and volition. The recurrent subluxations occur much more common than recurrent dislocations. So that's why it can be presented as a subtle finding. The direction can be purely posterior, it can be bidirectional, multidirectional. By definition, they all have primarily a posterior direction, but we'll get to this later on that the direction can be multifaceted. Again, it can be macrotrauma, microtrauma, atraumatic. Kim classification out of Korea, he described that on arthroscopic evaluation where type 1 is an incomplete detachment, type 2 was incomplete and concealed avulsion, type 3 was a chondrolabral erosion, and type 4 was a flap tear. So clinical presentation, it's males more often than females, young athletic population. Few can give an actual history of dislocation, and in the atraumatic and microtrauma groups, the onset is insidious. Pain can be anterior with traction on the nerves as the shoulder goes out the back. It can be posterior in the capsule. Often it's related to fatigue. The most common complaint is pain with flexion, adduction, and internal rotation. For some, it may only be limiting in sports, but others it may interfere with ADL and with sleep. So the signs are subtle. It can be tenderness that's diffuse or localized along the posterior joint line, or again with traction with the arm going out the back. It can present with pain at the biceps tendon. Usually has a normal range of motion. Impingement signs in general are mild, but Hawkins' impingement sign with that adducted, internally rotated position can push the shoulder out the back. There are provocative tests, the posterior stress test with the patient upright, stabilizing the scapula and applying a posterior force with 90 degrees of flexion, adduction, internal rotation. Positive test reproduces those symptoms. Push-pull test with the patient supine, 90 degrees of abduction, 30 degrees of forward flexion. Again, positive test reproduces the symptoms. Here's the jerk test that was described recently in a review article with Preventure. The arm is out at 30 degrees and elevated and posteriorly translated with the scapular spine stabilized, and that reproduces the symptoms. And then here's the Kim test, not dissimilar, but the arm is basically, the humeral head is abducted, as you can see in the lower picture. You have to test for other directions of instability as well as hyperlaxity. You have to check for the sulcus sign at 90 degrees of external rotation, and always do the anterior apprehension test because that could be a sign of anterior instability. The patient may be able to sublux or dislocate when asked. Don't confuse that with anterior instability. Another sign is subtle, but it's scapular winging. So in posterior instability, you can find a patient that does have scapular winging unrelated to long thoracic nerve palsy. Diagnostic studies, usually not that helpful. GAD MRI will often show the lesion, but if it's a redundant posterior capsule with stretching, you may not see that. Humeral head sublux is greater than 25%. You have to have a high index of suspicion. The gold standard is arthroscopy to check capsular laxity and check the reverse Bankart lesion. Sometimes it's reported as rare in some studies, others up to 50%. And again, rule out anterior capsular labral pathology. Non-operative standard PT for 6 months with strengthening, avoiding the provocative position. Many of these patients will improve. Operative indications are pain, instability, and interference with ADL. Patient selection is the key to success. A habitual voluntary dislocator needs a psych consult. They don't need your scalpel. Involuntary are good surgical candidates. So here's a combination of a slap lesion and a posterior Bankart. What are our treatment options? First of all, let's look at portals. These are, number 4 is the medial accessory portal. Number 3 is the standard portal. Sorry, 3 is the anterior portal, and that's going to be your viewing portal. This was described by Goubier in 2001 to do a posterolateral portal, and this has evolved to be the essential portal to get to these lesions. In his article, he put the spinal needle 1.5 centimeters lateral to the acromion at the posterior third. Nord and Burkhardt have re-described that, depending on the size of the patient, 2 to 4 centimeters lateral and then 4 to 5 centimeters posterior. And this broccoli shoulder, as I call it, these are the one furthest away. This one, which you see, is just straight lateral. Depending on the version of the glenoid, allows you to get down to the 6 o'clock position. So those are safe portals. They've been well described. This is from Keith Nord's work with dissection showing the location of the axillary nerve. So basically, there's a localization with the spinal needle. You're coming in at a 6 o'clock position and at a 45-degree angle, and that's going to allow you to put in an anchor. Can I have that video? So here we are after creating the portal. It's a right shoulder looking into the posterior aspect. There's the Bankart lesion. We're using a liberator to free things up, and again, that's part of, as Ben described in the anterior shoulder, essential to repairing this lesion. Take a shaver and get rid of some of that cartilage debris. I don't hesitate to use a ring curette if there's a particularly large mushroom cap, because I want to get down to a bleeding bed of bone. See the anchors coming in here at 45 degree or dead man's angle, as Burkhardt described. Important here is that you go inferior to the suture because you're going to create a capsular shift by bringing one of those limbs of suture through inferior, and when you tie your knot, it'll shift nicely superiorly. This is done through one cannula, but you can have accessory cannulas if you have other work to do. This just happened to work well. So you can see it's going inferior in the capsule. We're about 1 centimeter off, so the nerve is not at risk here. As you tie down, you see the tissue buttress come back and shift up nicely. Then I always put in at least a second anchor, sometimes a third, because I want to, again, shift that tissue from lateral up to superior. And that'll create a nice buttress posteriorly. Again, a variety of suture passing devices, a variety of anchors. They all seem to work quite well. Thanks. So what are the research and results? Well, McIntyre and Buddy Savoie, who's speaking today, back in 1997, reported on 20 shoulders. They had 12 of 20 posterior Bankarts. Half of those lesions also had a reverse Hill Sachs. They used a supraclavicular portal and tied the over the clavicle or the scapular spine. 2-year follow-up, they had a 25% recurrence. Here from 1998, Eugene Wolfe described a capsular plication with and without suture anchors. 14 patients, pain, strength, function, stability, range of motion were good. It appeared to be a promising technique. Kim in 2003, 27 patients, UCLA, ACS, and Rowe scores. 18 had a strip capsule, 22 had a stretch capsule, 26 returned to pre-op sports, and 1 failure with those UCLA grades. Jim Bradley reported on a prospective study of 100 shoulders. Unidirectional instability had a subset of 51 contact athletes at 27 months. Contact athletes had the same outcome, with 89% returning to sport, with 67% to the same level. So there is a diminution in an athletic population. Radkowski in 2008, 107 shoulders, good to excellent, 89% in the throwers, 93% in the non-throwers. But throwing athletes were less likely to return to their pre-injury levels of sport at 55% compared with non-throwing athletes. Some work was done on the biomechanical effect of specific labral and capsule lesions. If the posterior capsule was injured, 53% increase in inferior translation, but minimal change in posterior translation. If you had a posterior Bankart, there was an 86% increase in posterior translation. So the addition of a posterior Hagel lesion or rotator interval lesion significantly increases posterior inferior translation. Just for sake of completeness, though I don't think many of us do this anymore, thermal capsulorrhaphy, a small group studied in 2005, excellent or good. 3 of the patients refused immobilization, and they were 2/3 of the failures. Now, what about the bone block procedures that we were doing back in the 80s? Well, that's come home to roost. Here's a follow-up, 18 years, 11 shoulders, recurrent dislocation in 36, glenohumeral arthritis in 100%, and patients, 45% would not want that operation again. Again, what's the effectiveness of the Bankart repair versus an open bone block procedure? 16 cadavers with 3 measurements. Their conclusion was that an arthroscopic posterior capsulolabral repair more precisely restored posterior and inferior glenohumeral laxity and is therefore recommended as the first choice of treatment. Here's 107 shoulders by Radkowski with throwing athletes. They had good to excellent results for stability. Again, that returned to pre-injury level. That's a repeat of the previous slide. And what about for traumatic posterior shoulder instability? A bioabsorbable tack was used. This is back in 2003. Again, 92% good to excellent results. Again, another study by Bach showing good to excellent results. And a biomechanical analysis compared capsular plication with anchors, and the simple suture was technically easier and less traumatic versus the mattress. This study by Bocor showed that it was important to identify the reverse humeral avulsion of the glenohumeral ligament. That just points further evidence to Jeff's talk. And finally, the arthroscopic management of posterior instability, the evolution of techniques, Buddy Savoie, 92 shoulders, follow-up at over 2 years with 97% stable. And probably the take-home lesson here is to look at how many different other pathologies there were. Reverse Bankart lesion alone, 51%, but a bunch of those other patients had stretched posterior capsule, a combination, a rotator interval, and the remaining. So there can be a lot of pathology. It's really not that Tubbs-Ambry delineation that we had in our training years ago. It usually will take on other lesions. So conclusion, posterior instability is relatively uncommon, but you don't find what you don't look for. Careful history and physical exam are essential, and overlapping pathologies make diagnosis demanding. Addressing all the pathologies improves outcomes. Thank you.